and children. Managing both pediatric cataracts in children is a challenge for anybody, the pediatric ophthalmologist and the pediatric specialist. Yeah, as we know, again, the difficulty with cooperation examination, not really knowing what's going on in the posterior segment most of the time. We have to deal with parents' expectations, with long courses of medication, with tablets, systemic side effects. Parents asking us all the time, when is the treatment going to get over? When will my child be completely cured of the disease? In addition, amblyopia in children is sometimes occurs, and the need for general anesthesia for many procedures. So, before going in for anybody, any patient with pediatric cataracts, the counseling is extremely important. Both talking about pediatric intraocular lens situations, realistic visual expectations, because we don't really know again what the posterior segment is in many of these children, and repeatedly explain that the primary treatment of uveitis is essential and the need for follow-up is important, otherwise any amount of surgery not will be there. The good news is that the vast majority of childhood uveitis intraocular lens implantation is safe. All forms of multifocal choroiditis, toxoplasma, toxocala, retinal vasculitis. There are a whole lot of types of uveitis and parauveitis in which the intraocular lens implantation is not a major issue. Inflammation that you see post-operative is not very different compared to what you see in other patients in the same issue. Where you need to work a little more is with pediatric intermediate uveitis. And here, because the inflammation is centered around the region of the lens and the zonules, there's always a great deal of post-operative and pre-operative management required. And the severe forms of uveitis, where there are a lot of structural changes in the anterior segment, even with non-GRA uveitis, intraocular lens is still best avoided, and lenses clinically is what we would prefer. And in GRA, of course. And in the back fixation is not possible, because that is the preferred option. In my case of uveitis, surface lenses are dominant. But we would prefer to avoid spindle fixated IOLs. Now, if for some reason you're not able to put an intraocular lens while the surgery is going on, better to leave the child at home and put it much later, once the uveitis is under control, put in the secondary much later. Now, the juvenile rheumatoid arthritis, again, the rule is intraocular lenses are best avoided. Because in these children, even with lensectomy and vitrectomy, on a long-term basis, the rates of glaucoma, eventual crisis are quite high. And there are a lot of conflicting reports in the literature, partly because GRA is one part of the spectrum of juvenile idiopathic arthritis. And there are many other forms that do well with intraocular lenses. Many forms of JIA, or juvenile idiopathic arthritis, that do well with intraocular lenses. The classic GRA, which fit in the criteria for juvenile rheumatoid arthritis, does not do well with intraocular lens implantation. This is not a patient with GRA, but there are plenty of children who come with structural changes, extensive anterior pain, very shallow chambers, either low pressures or high pressures. And these are eyes that should not go in for an intraocular lens implantation. It's best to do a lens implantation. Once you've decided on the surgery, it's important to plan the surgery at a time when the uveitis is relatively under control. Decide on whether you're putting a lens or not, amount of steroid cover, many other things. Because it's a child and you're going to put the child under general anesthesia, if you want to give periopic injection at the same time, go ahead and give it at the time of the surgery. Now, just briefly going through the steps of surgery again in pediatric uveitic cataracts. Now, most of the time when the cataract is near close, and you choose about staining the intraocular lens, I usually stain the capsule before putting the viscoid assay. And then, after that, you need to put in the hooks. Now, separating disposable irises are often preferred, especially in pediatric uveitic cataracts. They provide reliable pupillary dilatation throughout the surgery. There is a small matter of using for additional side folds, and the chamber can be shallow, but it's not a big issue in pediatric uveitis. Then, now with metal iriscopes again, very often you don't need to use any additional side folds. You have a traditional, the two side fold approach. Use the metal iriscopes, stretch the pupil. You will get adequate dilation for 4 to 5 millimeters. And you need to combine this with a good high molecular weight viscoelastic agent so that you have reasonable dilation during the Rexus procedure. Now, Rexus again needs to be, at least in children, needs to be usually with Utrata automatic capsular forceps. In many areas of the capsule that can be calcified, you need to cut with scissors. But once you finish the Rexus, check that it's intact and we move on to the lens aspiration. Now, lens aspiration fortunately in children finishes rapidly, and we move on to the part of scorching cleanup and primary procedure, cap scorching. A good scorching cleanup is required in patients with uveitis, and once the posterior cap scorching is over, we get the bag with good viscoelastic agent, and it's essential in uveitis to get the intraocular lens within the capsular bag. If for some reason it's not possible to place it within the capsular bag, then a 3-piece lens in the surface may be possible in mild cases of anterior uveitis. So when we're dealing with patients with extensive cyclically and other issues, it's also important to do a surgical PI at the time of finishing the cataract surgery. Now, after cataract surgery, it's not the end of our problems because patients with uveitis, the abundance of deposits on the intraocular lens is quite common. And as you see, the entire first year is more or less, we are all the time busy repeatedly adding these deposits on the intraocular lens that form both anteriorly and posteriorly. You need a combination of medical treatment as well as repeatedly adding these clear deposits. Because after doing the cataract surgery, we still need to provide a clear visual access for the patient, and sometimes we may not be able to achieve it with these deposits. So we have to keep doing this regularly, and which is why the issue of follow-up is extremely important in uveitis. Because even after the cataract surgery, there's still almost a year and a half worth of management that goes on before you can sit back and relax and say that okay, fine. So now we don't have to do too much work with the intraocular lens. And of course, no need to mention this in this audience. The issue of amblyopia. As a conclusion, for pediatric uveitis, it's important that we have about managing we have to know about managing the small pupil, place intraocular lens within the capsular bag, provide tight perioperative control of the inflammation, monitor for complications of secondary glaucoma, and of course, without parents and family's help, we will not be able to achieve. Thank you.